The entrance of the ear canals, at least the left one, also when we do the right procedure, you'll also see that it's got loads of hairs there. And it's quite a lot of hair, it's almost like whiskers. And other slight issue is that some of these hairs have become loose, and over the years, this procedure, this wax impaction has been there for many, many years. The patient had been using cotton buds, so they've actually impacted a lot of these hairs deep into the earwax, so it's become matted, and matted earwax is very, very hard to remove because it's very hard to get a suction grip. So that's challenge one. Challenge two is the patient's ear canal anatomy. He's got very, very narrow ears and quite twisty ears as well, so quite bendy ears. And therefore it just makes it difficult to use other instrumentation when you've got really bendy and narrow and twisty ears. So we're just working laterally near the entrance. This wax is quite soft. Once we remove the more lateral wax, and this is the same for both ears, you'll see that the earwax almost is like chewing gum, stuck, impacted right up against the eardrum. You can see this consistency. It's very kind of wet and stodgy. And just manipulating this forwards, wriggling it out. You can see all the hairs. You can see the colour. It's very dark, so it's oxidised. It's been there for a while. So we've got the lateral wax out. So all this wax is beyond the second bend now. We're just loosening it off the anterior canal wall. So when we say the anterior canal wall, we mean the front part of the ear canal. So the front part of the ear canal in the case of the left ear is on the left hand side, and the anterior canal wall in the case of the right ear is on the right hand side, and the vice versa for the posterior canal wall. So posterior means the back part of the ear canal, so in the case of the left ear it's on the right hand side, and in the case of the right ear the posterior canal wall is on the left hand side. Slowly but surely just bringing this plug forwards. And because it's a narrow ear, we've got very little room to manipulate the instrument inside. So when I'm trying to loosen the wax plug by wriggling it and moving it in little concentric circles, there's not much room for manoeuvre in there. So we managed to drag this wax near the entrance, and it got trapped, so just went back in and cleared it. And behind that, we just brought along with it a bit more wax. This is quite sticky at the top. You can see all the hairs, again, it's all matted. And we're just working on the posterior canal wall now. So this is the back part of the ear canal, and a lot of this wax is matte. You can see the hair strands just here where I've got the suction grip. And I'm really wriggling this forwards, and I can feel at this stage that there's a lot more to come out. It's not quite done. I could feel this part of the wax I was extracting, it was going to come loose with the main body of the wax a bit deeper in. And when the patient attended, it was virtually unable to hear me. It was one of the most severe impactions, I would say, I've seen in a long, long time. So this last plug, which is deep in the ear now, this is trapped in a narrowing called the isthmus. So the isthmus is about 0.5 centimetre away from the eardrum, and we all have a natural narrowing, and this patient's managed to really impact it and embed it in this narrowing. So once the ear canal narrows, it widens again. So the wax beyond the isthmus, it's larger than the narrowing. So we're trying to bring through a large object through a narrow aperture, which is always difficult. And I was just lifting it off the back canal wall. I could feel a bit of resistance. Again, this is like chewing gum now. So I've just put a bit of olive oil drops in. Now we can't really use any of the instrumentation to remove this now. So when we're on the bony part of the ear canal, very close to the eardrum, if I was to use an ear hook, the plug itself is too soft. It will just dissect it. And how am I going to get this hook in and behind the wax? It's completely impacted against the canal walls. There's no natural opening. Same with the Jobson horn. It's just going to kind of almost cut through this. And again, there's nowhere for me to put the Jobson horn. When you use these mechanical instruments, they're designed to go in and behind the plug of wax or keratin, and you extract it forwards. And obviously forceps, it's just too soft. It's just going to dissect it and snip it. It's going to cut it in little pieces. You can perhaps see the narrowing just to the right. You can see the ear canal, it comes in a bit, it protrudes inwards. So that's near the isthmus. the canal itself is almost engulfed itself around this plug of wax, and it doesn't want to let go of it. And this is perhaps the worst consistency of wax. It's, as I said, I've described it as a chewing gum consistency. And once more, it doesn't help when you've got all these hairs in the ear. It really does reduce the suction grip. And if you look at the top part of the ear canal there, you can see just the valley shape. You can see just how it narrows. It's almost like a roof, the top of the ear canal. So I'm actually targeting the top of the ear canal now. So there's a few hairs that are slightly in the way, but it's not really affecting me trying to work away at this wax. And with these types of procedures, sometimes it's just patience. You just got to continue, put drops in at the right time. So I think I've used olive oil drops on a couple of occasions, and I'm going to go back in a minute and put some sodium bicarb just to try something different, to see if the sodium bicarb has a better effect with loosening this plug. And just see that top part really narrows. So the idea here is when you've got this isthmus, this narrowing, when it protrudes back outwards, it creates two recesses, one inferiorly, so to the base of the eardrum, so it's almost like a trench, and one to the left in the case of the left ear, that's the anterior recess. And quite often when this wax plug is impacted, it gets trapped both in the anterior recess and also the inferior recess. So what I'm trying to do here is lift this plug of wax upwards out of the trench almost. So I think this is where I put some sodium bicarb drops in, and I'm going to swirl it around just so it gets to the top of the ear canal as well, where that plug of wax is. I've just gone back in. I'm trying to suction at the same time. I find sometimes when you put drops in and you suction at the same time, it has a better effect. So before we kind of go for the wax plug, I'm just being careful just to suction any excess oil and drops. See the consistency, what I was referring to earlier, like a chewing gum type of wax. The suction probe itself, you can see the mark it's made. It's not really suctioning, it's almost like a fudge type, and it's just indenting inside on the surface of the plug of wax. And that's why if you use an ear hook or Jobson horn, it's just going to completely just dice through it as opposed to bringing it forwards. You can see it's still really matted here. I asked the patient how long this impaction has been for, and they're saying at least 4 to 5 years. And I did ask why they didn't do anything before, and they said well, they attempted to have it removed years ago when they first noticed, and it was really uncomfortable. So they just persevered, and then obviously COVID hit, and they decided to wait. But it came to the point now where they were really struggling to hear at work. The patient's wife's not too pleased, and it was actually her that put the patient in with us. I'm really just trying to bring this down. You can see how much, I think you can tell just by watching the video how much force I'm putting to bring this out of that top ridge where it narrows. Yeah, I've just put some more drops in. Now, if the patient was asleep or they've got some local anaesthetic, would have probably been a bit easier, can be a bit more gung-ho, could have probably used a hook or scoop just to get in and behind the wax plug, although it would be hard to remove it, but you can almost lift it off. With the patient being awake, because it's on the bony part, it'd be very uncomfortable. So got a large plug there, but there's still more. So just going back in. See, in the UK, audiologist, currently at least, are not allowed to prescribe any topical lidocaine, which is a local anaesthesia, which is what some ENT doctors use. And sometimes you can also inject a bit of lidocaine at the back of the ear as well to numb it. And slowly but surely manage to get this out. You can just see how bendy this is. I hope that there's the eardrum, nice and healthy, but I don't know if you can appreciate the bends there where we're going up and then to the right and back to the left. So left ear done. This is the patient's right ear. It wasn't any easier, if I'm honest. The patient said they felt the right ear wasn't as bad. But to be honest, it was just as bad. And again, we're just near the entrance. The entrance is really, really narrow. It's kind of sticky wax here. You can see the consistency. Again, it's matted. It's large. The patient, again, cotton buds, been poking this really deep over years and years and years. You can almost explain it and compare it to wet sand in a bucket. If you're on the beach, you fill up your bucket with wet sand and then you use the back of the spade to hammer it in, and it just really impacts it, makes it really, really difficult to remove. So just put some drops a bit quicker, a bit sooner, and you can see the suction probe just about fits in the ear, so it's really narrow. Once more, got the lateral wax out. That came out pretty straightforward. Now this is where it's large, and I'm once again trying to lift this out of the inferior recess. At the bottom of the ear canal is a little trench, and as I bring that up and away and then go to superiorly to bring it down, almost rolling it forwards into a ball, you can see I'm working on the anterior part here as well, so to the right of the ear canal, trying to just loosen that off the canal wall. You can just see on the right hand side the ear canal narrows, it protrudes inwards and then it widens again just there. So this wax plug is stuck behind that. And again, we're on the bony part of the ear canal. You can tell by the colour of the wax, it's really dark, it's oxidised, it's been there for a long, long time. So again, for me to use a hook or a Jobson horn, I would need to get almost in and behind this, which would mean making contact with the bony part of the ear canal, which would be really uncomfortable for the patient. So we're just persevering with suction. Actually do finish off the procedure with a hook. So near the end, I managed to bring this wax plug forwards a bit onto the cartilaginous portion, could create an opening at the top, and I then used a hook to glide in at the roof of the ear canal and turn the hook and then bring forwards. If I was to put a hook now and do that at the top, it would probably make contact with the eardrum. It would be very uncomfortable. And similar to the left side, it's this chewing gum consistency of wax. Probably the worst type. It's very, when you've got a chewing gum type of wax, there's a lot of keratin involved around the plug of the wax. So this plug of wax is engulfed by some keratin, which is softened, it's dead, and it's become a bit stodgy and sticky. And again, you can see all the hairs, it's matted again into the wax. And again, the patient's been using cotton buds in this ear. At the end, we spent a couple of minutes just really explaining all the do's and don'ts about ear care. And there's more don'ts than do's, if truth be told. So when you've got a wax impaction, or irrespective of whether you've got wax impaction, actually, just avoid watering the ear, guys. Water's bad for the ear, can develop swimmer's ear, and don't poke, it's just going to go one way. If you think about the cotton bud is probably the same diameter as the suction tip that I'm using, and the suction tip just about fits in this ear. Therefore, a cotton bud is just going to push the wax in one direction, that's further in the ear. So I just put some sodium bicarbonate drops in there to see if that helps. Sometimes the hairs can be a bit of a nuisance, they can get in the way. When we train our clear wax delegates, I always compare those hairs to, think about in the UK, I don't know how it is in America, as I know a lot of viewers are from America, but when you've got some takeaway, fast food restaurants, and the kitchen where it's connected to where the counter is, the cashier is, you normally get an open door, but with chains coming down, separating the kitchen from the front part of the restaurant. And that's what I compare the hairs to. So when I train the clear wax delegates, I always say, just trying to get through the hairs if you can, get through the door, get through the entrance of the ear. Sometimes it's hard because it's like this, the ear is very narrow, and these hairs are almost like whiskers, they're very thick. Some people ask, why don't we cut them? Well, cutting it's not really going to it might improve the views ever so slightly, but it's not, as you can see, it's not really impacting my view. It can sometimes just be a bit annoying when you are watching it, but it's not preventing me from removing the wax. And when you cut these hairs, they're just going to come back anyway, and come back very quickly. Sometimes they can come back thicker. I mean, there is odd occasions where the ear canal is so full of hair that it does affect your vision. You can't see anything, and then I sometimes pluck them. I use forceps, and you just pull them out the roots. And I don't know if you can see there where the ear canal narrows again, just like it did on the other side. Again, I'm just targeting the base of the ear canal where the trench is, the inferior recess. I'm just trying to pull this upwards and out of the trench. So you see, I'm going in, lifting it up, and I'm going back in again and lifting it upwards. So we are now bringing this forwards towards the entrance of the ear. You'll just put a bit more drops in just to lubricate this. So the drops also, not only does it bind the wax together and stops the suction probe from getting blocked, but if you've got a ring stuck on your finger and you put a bit of soap around it, it just helps you loosen the ring out off your finger. And sometimes oil does that as well. Just when there's a tight space there and there's a bit of friction, the oil just helps to lubricate that area and to bring the wax forwards. So we are making progress. We're just near the entrance. Bring this plug forwards. You can see I've got one piece out here. Go back in, but there's another piece, very deep, large still. Now what's interesting, I'll explain it now so whilst you're watching. Once we get this plug out, the patient has got what we call an autoatecotomy. The top part of his ear canal near his eardrum has been eroded. So previously this patient's eardrum has been retracted superiorly in the attic region. So the attic region is the top left in the case of the right ear. When the eardrum gets sucked in, it can start eroding the bone, and worst case scenario, it can start eroding the ossicles, the three middle ear bones. But in this case, the ossicles are still intact, the hammer, malleus, what we call the malleus, the anvil, what we call the incus, and the stapes, what we the stirrup, what we call the stapes. They appear to all be intact. We can only see the hammer bone, but the eardrum, because it had been sucked in against the top part of the ear canal, it's restricted the blood flow to that part of the bone, and that bone has begun to erode. So within dichotomy, sometimes you just be careful that the eardrum, there's no cholesteatoma formation. In this case it's not, but the patient is going to be prone to having the eardrum get sucked in, and that piece of bone at the top of the ear canal, the roof, when that's eroded, it starts to reveal some of the middle ear structures. And with the hammer bone, the hammer bone is much more than what we can see on the eardrum. That's the main body of the hammer bone, if you like. But the hammer bone also has a neck, we call it the neck of the malleus, and on top of that it's got the head of the malleus. And in this case, because that bone's been eroded, you're able to visualize the neck of the hammer bone. So it really does give an insight into the middle ear. Okay, I'm just bringing this forward. So you can see how much hairs are there. It's really matted. So now that I brought this plug forwards, I'm now able to use a hook or other instrumentation to safely remove it, because the hook's not going to make contact with... You can see I'm just actually purposely bringing the wax down at the top to create an opening. So I've created that opening. We know we can put the hook in safely now. We're not going to touch the eardrum, because it's almost blind sometimes when you put the hook in, because you're going to get in behind. Slowly bringing this forwards, and it's come out in a big piece. And you can see top left, this bit here where I'm focusing on, that's the neck of the malleus. You can go, it's going upwards. It's clean, it's not infected, there's no cholesteatoma. Sometimes you can get dead skin collecting in that pocket, but it's not. And this is a close-up of all the wax that I've removed. Just see how dark it is, it's almost black in appearance. So you just knows how, you can just imagine how long it's been in the ear.